Hey, everybody, John Marshall with Oncology Unscripted, even though I've got a little bit of a script right here, but don't tell anybody. Today, we're going to talk all about dosing of medicine and do we have it right or not, particularly with some of our newer cancer medicines. And I'm going to really drill down on a couple that I know a lot about that I hope you will use in your own practice, quite honestly, and make your life a little easier. And more importantly, your patient's life a little easier. From a science perspective, I just came across really yesterday in the New England Journal an article that piqued my interest because it not only went very nicely with the theme of our episode today, but around dosing, but really value in terms of what's it worth to get a little bit more survival. And this was a study. It's a metastatic lung cancer study in the New England Journal of Medicine. I've got an actual copy of it right there. There it is. And this is by Cho et al. It's a very important study. It's the Mariposa study. You all know about it. It's amivantamab. There you go. Plus lazertinib, which is, I guess, like Lazarus from the New Testament, maybe, maybe not. But this is in patients with EGFR mutated non-small cell lung cancer. And of course, the current standard of care is osimertinib, and relatively easy medicine to take, has some side effects. The doublet wins in the end of the day by a small amount, and that's with both PFS and trending towards OS. But I went to the toxicity table because do we have the doses of these medicines correct? And so maybe that's reflected in tox, and I'll come back to this in a little bit, but there's not equal toxicity at all. In fact, the doublet therapy has essentially double the amount of grade 3 toxicity. And the investigators are fairly bold in saying, however, the incidence of grade 4, which is almost dead, and 5 dead or discontinued treatment were similar between the two groups. So now we've elevated it. Don't pay attention to grade 3 toxicity. We know that's going to be different here. Let's look at dead and almost dead, grade 4 and 5, and see if that's different. And it really struck me when I looked at the deltas on the advantages, the clinical outcomes, and the deltas on the toxicity, that is this really worth it? Should this become a new standard of care? New England Journal usually doesn't print things that it doesn't think are at least at risk for being the new standard of care. So those folks out there who take care of lung cancer are going to have to figure out if this really reflects a new change and is that worth it? And really why I picked that paper, it's important, but to me, it's all about dose. And I think we are overdosing people. I am old enough to remember that when chemotherapy was the thing, that we needed to get to what we called the maximum tolerated dose. And this was how much could you give? You all know what this means. How much could you give without bumping the patient off? Because the principle was that more was better. Now, I want to reflect on this a little bit because we learned pretty clearly in some cancers that was true. Germ cell cancer, some leukemias, maybe adjuvant breast cancer, but that dose intensity mattered in those diseases. But let's look at adjuvant breast cancer, because when I was a junior faculty member here, we were doing bone marrow transplants in the adjuvant setting for stage 2 and 3 breast cancers. So we were doing myeloablative therapies because more was better. And if you know that story, you know that the people who were leading some of those papers out of South Africa ended up committing fraud. Their results were fraudulent, and many, many women were exposed to bone marrow transplants because of their data suggesting it might be helpful, when in fact it was not. So more was not better in that scenario. And the other place that I was living at the time, again, 20, 30 years ago, was the advent of capecitabine. Simple drug. You use it a lot in your practice, I am sure. But what dose and schedule do you use? Do you remember, were you around when the actual dose studies were done? Back in the day, we would not only do something called maximum tolerated dose, we would then have a supplemental study of recommended phase 2 dosing. And very often that meant a randomized clinical trial of different doses and schedules of the medicine, looking for both toxicity and efficacy to see which one worked the best. Well, yep, they did that with capecitabine back in the day. And they looked at continuous dosing, right? Just giving it continuously at a certain dose. They looked at 2 weeks on, 1 week off with leucovorin, 2 weeks on, 1 week off without leucovorin. Those two doses were a little different. And guess what? All three had exactly the same outcome in terms of response rate and progression-free survival, all of that, exactly the same. The continuous dosing had the lowest toxicity, but guess what? We picked the one that used the most capecitabine pills, not leucovorin. You could use fewer pills if we threw a little leucovorin in, but this was just capecitabine at what we now know as its dose, 2 weeks on, 1 week off. That sold the most pills, not because of benefit, but because dose intensity at the time mattered. And we are still clinging on to that dose and schedule. Many, many people are, whether it's a Xelox regimen or just capecitabine or maintenance capecitabine, but it's not correct. The correct way to give capecitabine by John Marshall: fixed dosing. Never use the small pills, only use 500 milligram pills. Size up your patient. Do an estimate of creatinine clearance, because this is a renally cleared drug. Most patients I start at 1,500 milligrams, 3 pills in the morning after breakfast, 1,500 after dinner, Monday through Friday, because you know what, if radiation doesn't work on the weekend, neither does chemotherapy, every week. Okay, so if you're a 2 week on, 1 week offer, you're giving it 14 days every 3 weeks. My way, I'm actually giving it 15 days every 3 weeks. And because you give that little weekend off, the hand-foot syndrome is less. It doesn't build up nearly as much. Are you giving the right dose? If somebody comes back in within a month or two and starts to have some hand-foot syndrome, if it's mild, you're probably at the right dose. If there's no toxicity, you think about increasing it. If there's a lot of toxicity, you need to decrease it. We all are pretty clear on that. Some of us like to decrease it by pill count and keep the continuous dosing. Others like to do 1 week on, 1 week off as a modification. One little trick to know that you're giving the right amount: check your patient's MCV. They've been on capecitabine for, I don't know, a couple months. You'll notice that MCV will be going up because that's the antifolate effect that you're seeing. You got your own little built-in micro biomarker in your CBC of every patient that you're giving capecitabine. So I'm telling you, switch out to this dosing. And you can give your ox every 2 weeks or every 3 weeks. I'll leave that up to you. That's another matter altogether. Tony Saab taught us how to use regorafenib, Stivarga, because we knew that if we gave full doses, 160 milligrams daily, it was too much, too spicy. Lots of patients said, forget it, I'm not taking that drug ever again. Tony showed that if you started lower at 80 and then inched it up and then inched it up, you did a lot better. Now, what's the right dose of a tyrosine kinase inhibitor? The studies are done with maximum tolerated dose. Give as much as you can give. More is better. Use that in the clinical trial. But more and more we are seeing that you don't need to give that much. But are we comfortable in dose reducing? Are we okay with saying, all right, I'll just cut the dose back because Marshall said it's okay? No, we're not, because we don't want to regret that it was our dose that maybe it didn't work. So we're feeling compelled to give the dose. Even the insurance companies are mandating that we give the dose that is in the package insert, when for a lot, maybe most of these TKIs, we don't need to give nearly that much. I believe the same is true for immunotherapy, because let's face it, those patients whom we stop for IO toxicities, they seem to be doing okay. So maybe we don't need to do nearly the duration or as often. If the way the drugs work is the way they say they work, then you wouldn't need to have it continuously exposed all the time to patients. So we're probably overdosing TKIs all the time, and we're probably overdosing immunotherapy. Another colon cancer drug that I think is important to understand is Lonsurf dosing, trifluridine, tipiracil. What a crazy regimen that was. So 5 days on, 2 days off, 5 days on, 2 weeks off. It takes forever just to coach the patient on what to take. And there are 2 pill sizes and all of that. And myelosuppression is the big side effect of that regimen. Well, we just looked at that and said, that's crazy. Just give it every other week. So we still stick with our Monday through Friday because it's easier for patients to remember. And instead of 2 weeks in a row, we give it every other week. And believe it or not, that has essentially solved a lot of the cumulative suppression, myelosuppression, the nausea, all of that stuff that you see with that drug by getting away from the package insert, dose reducing maybe a little, using only 1 pill size again to get your optimum dose and schedule. So we need to understand better how to dose these medicines. The problem is we don't use them that often, many of them. So we're dependent upon looking stuff up and what the package insert and what the insurance company and what the guidelines say. We all don't have a person who's an expert on speed dial that you can say, well, what would you do if you were giving this patient this treatment? So we clearly need an improved resource for all of us to understand what the correct dose is that we need to use day in and day out to optimize our patients' both benefit, but also toxicity, so that we know that we are doing the best job possible. And so to that end, I have invited not only a lifelong, career-long friend and mentor, but really what I think is maybe the world's expert in this space, and that's Dr. Mark Rattain from the University of Chicago. He cares passionately about this and is actually doing something about it. So listen to this interview with Mark Rattain.